All right, well, welcome to today, October 13th, Aspirational Care Advisors Group. Robin Faust is going to do a presentation on a calculator that she's created for calculating the return on investment by engaging direct primary care. So Robin, go ahead.
Well, thank you. And like I said, yeah, we did develop this for that very reason, to help benefit advisors, brokers, consultants, and their employers make more informed decisions around will I get any return if I invest in direct to primary care. We've always been passionate about it, so we're excited to support that ability. The first thing we do, now this is a good size group. We do it for all size groups. When we're doing it for smaller population, smaller employers, generally what it does is it tells you exactly what enrollment rate you need to have to expect any savings. So it's, but we time and time again, we are seeing some savings estimates. By the way, too, with the smaller employers, we remind them, as the larger ones, that it's not all about the money. I mean, there really is a difference in how your insured members will value and appreciate the quality of care they're going to get through this model. So we hope they don't just focus on the financial, but as we all know, that kind of helps with making decisions. This particular group, like I said, I could have brought a smaller one on board, but I went ahead and brought the larger one just for this demonstration purposes. We do source all of our research and data that we use. We do hope in the future, as we grow, we can actually adjust the actuarial projections used by, in this example model, by that really come from Milliman, and go ahead and adjust them based on what we're actually seeing in those groups that implement. This group has about 36,000 lives. You can see that breakout down here where my cursor is on line 30. That results in about 342,000 member months. Then you can see the plan paid medical and plan paid pharmacy broken out as well. We always generally work in plan paid because that's what the employer is responsible for, and that's what they care the most about. So in this instance, then you are now working with our kind of quote secret sauce is looking at how to attribute from claims. We can work with de-identified data if it's a prospect and or if it's an existing client, like we've done with many of our clients interested in this DPC arrangement. We can work with real data, but we end up essentially attributing the spend to 5 buckets. Those 5 buckets are really depicted over here to the right. And I'm gonna, oops, I went to the wrong, let me go back here and shift around. I can't get to my, let's just do it this way. So as you're working over here in the model, you'll begin to see how we attribute that gross spend, the 152 million, to 4 these buckets. The first bucket, in an outpatient, which is hospital. So that for this particular employer, we have about 46% of spend going to hospital. Pharmacy, 26%. We have 4.2% of the gross spend, or over here you can see the actual spend, 6.4, almost 6.5 million attributed to specialists, and 7.3, or about 11 million attributed to primary care. Now, when TPAs or any payers give you data, sometimes you are not able, by how they give it to you, to cleanly attribute to those 4 buckets. So if anything, we say this is a conservative assessment and calculation, because in this case, almost 17%, we were not able, based on the source of the claims information, to cleanly attribute to those 4 buckets. That's 25 million. In this particular case. The next thing we're going to talk, so hopefully you're seeing over here, this is the gross spend and the percent of spend attributed to those 4 major areas. And then we're going to talk about variables. And as Daryl said earlier, right now we have the variable, it's called replacement percentage, but it equates to what percent of the population enrolls, engages with, signs up with a DPC physician. So we have it at 60%. we have a few variables that are in these blue cells. Now I'm going to go and change it, but I want you to pay attention first to really column M, which in green, and that will adjust the spend accordingly based on enrollment. So let's put it up to 75%, and you can see it adjust everything from there on based on the enrollment that you're expecting. When we go out, we do several examples. We'll look at 10%, 25%, 50%, 75%, unless it's a small employer and you know by the design they're going to say it's going to have to be 100% for coverage. You must sign up with a DPC physician that's offered to you. So are there any questions so far? Is everybody with me?
Yeah, so just for clarification, column M is simply adjusting the gross amount by 75%. So if I'm only expecting 10% to go into DPC, that column M will go way down because only 10% of the members are going to be attributed to DPC. But it's assuming that it's evenly spread across the population, I would assume, correct?
Yeah, we're using member months, remember. So we're also taking that in consideration. It's not just people, it's member months attributed to those individuals. And just to clarify, in case people aren't familiar with member months, I know we have a very knowledgeable group of people here, but just in case, that would be an example where Robin's been there all 12 months in that employer and insured by them, but Daryl's only been there 2 months. And Heidi's been there 4, but while Heidi was there, she did have claims. So all of that takes that into consideration to member months and the spend that we're showing here. So I hope that makes sense. And that equates to the PM based on member months.
Right.
So the next thing you're seeing are those actuarial projections, and they really came up with a minimal to optimal savings range. So for hospital, we're looking at 15% to 25%. An example of that would be, admissions, hospital admissions, ER utilization. You're expected to see, and what we're seeing in our data analysis after DPC is implemented, we are seeing that occur. So that's first and foremost what you're seeing here. And it gives you the first look at the gross spend savings that you can see. And I'm going to up it so you can keep your eye on that red over on the far right. Let's put it at 50%, and you'll now see where everything is adjusted from that point. So right now we're seeing anywhere from 13 to 19 million in gross savings for this particular employer population. The next variable, some will use, some will not. This employer did. They typically are paying, an employer is paying a TPA or paying a third party to provide some type of disease management, medical management programs. And you really no longer need those in theories. Now, there's a lot of questions out there. I know other models will remove this, but supplement their own care management support for DPC physicians in between visits with those patients, etc. But it is what it is. You can use this or not. This particular group agreed that they didn't need, quote, disease management, but they had a centers of excellence they wanted to maintain. So where they were paying about $20 for both the COE and all the medical management, what we ended up removing from that spend was about $10 or 3.4 million from this employer group. And that just contributes back to their reserve, back to the savings calculation, because this will go back into the gross savings. Likewise, telehealth, they were paying 90 cents per EPM. You shouldn't need telehealth because, again, by definition of a DPC, you have 24/7 access by text, telemedicine, telehealth, email, phone, and so forth. So that was also agreed to be removed and added back into the gross savings at that point. So now you're down to 16 to 22 million in potential savings, gross savings. Is everybody with me here, or do you have any questions?
Anybody have any questions?
I will add one other side note too, I think interesting, and some of you may or may not agree, and that's okay. But I know for some of our clients, we have studied where they continue to pay their TPA or payer a rate for a third-party telehealth service. And when we studied the population, those claims, they had very poor utilizations, like maybe 12 out of 3,500 people went through that vendor for telehealth services, telemedicine. However, almost half of the population actually had virtual visits with their own physicians that they were going to. So we also contend, it's something, if they're paying for, it's being paid for and covered in claims. This is another expense they can add back in to invest in DPC or invest in other care management and health management services. The last variable is the cost of the monthly capitated rate. Now, you can do more sophisticated things around here, like a pediatric rate, adult and senior rate, but for now, we're giving you a blended rate. This does vary. We're seeing anywhere from 45 in some areas of the country to right around 95. But on average, you're seeing around 60 to 75, maybe more in that range for the majority of the states and the DPC arrangements that we're familiar with. This one has $70. I'm going to back it up. Well, maybe I'll back it down to 65. And when I do that, you're going to say adjustment over here. So let me point out that right now we're seeing net savings of 4 to 10 million net savings. But when we put in the $65, you're now seeing adjusted to net savings 5 to 11. So it depends on, what this is. I'll put it up to 90. So you can kind of get that understanding of what's shifting and what happens there. So for this particular employer group, I believe their rate was right around 65 though. Now, the other thing we do with this is, let's say this is great data, we want to implement it. If the group implements DPC, we will go back and adjust this model by putting in the actual sign-up rate, engagement rate, and the actual spend at that time prior to the DPC program starting. So in other words, we're adjusting this to a real baseline for the employer group, and then we can compare how did you perform against what was projected. And that's where, again, we hope through intelligence work and so forth that we'll be able to even perfect even more what we have based on Milliman's actuarial projections.
Well, and Robin, it won't be that hard once you've got a group that's been on for a year to segment all claims between those who had DPC and those who didn't, correct?
Yeah, and we're already doing that, but I think you need a lot more data than we have to really feel solid as to what those projections and those actuarial projections turn out to be. So we want to make sure our count is defensible as far as any adjustments that we make to this model.
Well, and I would love to ask the group what you're seeing, because the most important number on this whole thing is engagement. I'd love to hear from the group what you're seeing in terms of, are there some groups that are seeing 70, 80% engagement in DPC, or most groups only getting 5, 10? Heidi, I know you've got a lot of experience with this. What are people seeing in terms of ability to actually engage the employees in DPC?
So kind of, and Robin, commend you for your efforts here. With what we're seeing is that it depends on first, second, third year. And we normally see the trajectory like 30, 40%. With a couple of groups, we've been up to 50% first year with a very assertive value-based benefit design that supports it. We can see it. We've never been able to get past about, and this is because of turnover. There's a high level of turnover that changes this. But from the cohort standpoint, one of the things, Robin, that that would be an interesting, because we do it on our advanced data analytics side, kind of the cohorts and what we're seeing, Daryl, on cohorts. So people who are staying with the company longer, that they're the ones that we see that 60-70% that they don't get off DPC once they're on. It's more the adoption and then turnover that has an impact on those percentages.
Interesting. Very helpful. Anybody else have any thoughts about what they're seeing in the way of engagement, or anybody else have any other questions for Robin? Steve, you've got some groups that have been using some DPC. What are you seeing?
Yeah, I think a lot of Robin's tool, I haven't used it, and the reason is I can't seem to get enough DPC physicians in a location to really support an employer's plan. And so I'm looking forward to it, but right now I haven't had the right mix or the right connection, if you will.
Well, Heidi and Lee are working to change that.
That is correct.
And I'm doing everything I can to help them. It's like, that's what we need. While anybody else have any questions for Robin? I've seen this a couple of times now. I think it's really neat, and I think it's only going to get better. I mean, it's based on Milliman's studies, which is the best thing we have now. But I think the more and more that employers are willing to invest in DPC, the more data we're going to have on the true impact.
Well, thank you. I appreciate it.
I would love, and I don't know if Heidi, you want to do this, but I had an amazing call with her a few days ago regarding a transparency tool. Would you like to share a little bit, Heidi, about what you're doing with that transparency tool, and both on the employer side as well as on the hospital side? Or have I caught you off guard?
Yeah, no, not a problem whatsoever. It would probably be best served if we can show them kind of what we're doing. So maybe we can set up some time to do that. But one of the things that we've done is that we've invested a significant amount of money in using the machine readable files from both the hospitals and from the payer side. But that data set, because it's fairly new, and for those of you who are very active in the transparency laws, it started with the hospitals, and kind of the time line is the 2021 forward. And as of January 1, 2024, they're going to have to upload all of their charge masters, and we'll be able to see exactly by procedure what the cost is. On the payer side, their deadline was January 1 of 2023. So we've been ingesting this data, but what we've done to normalize it is that we have triangulated the data against claims data. So from the all payer claims data set, which is we're about 92% of all claims that have been adjudicated. So based on the hospital and the payer side, that there's still some gaps. There's no perfect data set, but there's still a lot of gaps in the data analytics. And so what we've done in that triangulation, we've also injected quality scoring, as well as within that, we've used CMS as a benchmark proxy. And so what we've been able to do is do a couple of things. The whole objective of us developing these two tools was, number one, that this legislation is disruptive in its nature. And so we wanted to build kind of crosswalks to help bridge the learning curve and bridge some of the medical efficacy and some of the other challenges that we see in the market by introducing these tools. So that was really our objective, but we developed a tool for the employer lands and we developed a tool for the hospital lands. And what we're doing on the hospital side or any of the healthcare delivery system, we're just starting with hospital systems because we have about 6,200 hospitals in the United States. So what we have done is with this new empirical data, because they've never in the commercial pricing, they've not seen what their competitors are charging either. There are antitrust laws, et cetera, that have precluded having visibility to that. And so a lot of these hospital systems that, you know, candidly right now out of the pandemic are struggling, especially in the community or rural areas, that they're using our data set to then more effectively negotiate payer contracting and to be able to effectively see, you know, who's contracting. And we're able to do it because we ingest both the hospital side and the payer side, that we're able to demonstrate exactly what, whether it's a DRG or CPT code, what that they're able to charge. And it does bring it to a normalization level because it's allowed charges. And so for all of you who know, allowed charges is that funny number up above, which is what's billed, okay, or allowed to be billed. It's kind of like when you're in a hotel room and you shut the door, right? And you go, they can really charge $675 a night for this room. You know, it's kind of that funny number at the top, but essentially the allowed is, so that number minus any discounts, which is allowed. And so we're able to normalize that a little bit. And that's real-time data. So based on the requirements, we're not looking in the rearview mirror. And so Robin, part of what we're doing, which is kind of interesting, is we're able to then through the data analytics show that doing direct primary care or doing any other point solutions or, you know, alternative health plans will be able to validate it through our data set as well. So it's a really nice validation tool. And this really, Daryl, speaks to, from the employer lens, all the new fiduciary responsibilities, even though they are under ERISA, being able to set up an independent review process for employers to evaluate their health and welfare plans. And the first primary look is, how do we evaluate the discounts in our networks? And so this tool allows basically a claims repricing to be able to look and evaluate independent of the payers. A lot of pushback, as you can well imagine, as to being able to provide the initial, whatever the current claims are, looking back historically and saying, okay, let's compare actual costs a year ago to current costs today, and what does that look like? So we're able to do that from the employer lens. The other tool, that tool is called TPNet. Then the other tool for the hospital side is called TP Compare. And because from the hospital side, they play two roles, both the hospital administrator, you know, outreach, delivery, care, you know, services to the population, but they're also the employer. So we're able to kind of bridge both of those. What hospitals secondarily are using this data set for is to do more direct to employer contracting and community-based programs. So this we feel is going to help them kind of crosswalk this to the employer population. So yes, that's what we're doing. Be happy to kind of share with you the functionality of the tool at a later date, but that's a little bit.
Well, and I'd love to do that. Let's schedule a time for you to come and actually show the tool. But I just want to underline how significant this is when it comes to hospitals and their view into how to price something. Having opened 3 brand new hospitals as a CFO controller, you know how we got our pricing? Had nothing to do with our cost, had nothing to do with our competition. It was, what's the closest sister hospital charging?
Yeah.
That was it. That was our benchmark. And if they were charging outlandish prices, that's what we charged. And sometimes it was literally just pulling numbers out of the air in a pro forma to say, how much do we need to charge to make lots of money to perform a procedure? So this will create an environment for the hospital industry that has never existed before.
No.
and is so desperately needed.
Thank you, Daryl. Yes, so that really is what we're doing. We'll be able to do that for ambulatory surgical. We'll be able to do that also for individual providers like multi-specialty groups, surgery groups, those types of things. So our objective is really to introduce kind of cost and quality accountability into the market and allow the data to tell the story. So I'd love people's
just one more
opinion.
pitch.
Sure.
If you are familiar, I mean, obviously you're all connected with employers.
Yeah.
But if you happen to be connected with any healthcare systems, let them know about what Heidi's created.
Yeah.
It's like the first to the starting line will be the first to the finish line. And so the sooner they can get a hold of Heidi's data and actually use it in their own strategies, the better.
Agreed. And there's been some, Daryl, to your point, there's been some really key aha moments as we've sit down, and again, I would recommend, depending on your relationship within those hospital systems, the CEOs very much understand, that expense reduction is the name of the game. Okay. And to be able to help them reduce their expenses through seeing this data and using this data empirically is key. But there's a lot of revenue preservation going on because there's been a race to kind of ambulatory surgical centers taking what's inpatient, outpatient, and they're now having to compete against those ambulatory surgeries centers. And so it's really been some aha moments seeing where they not only compete, not just in Medicare, because they've seen that, but really in the commercial space. And it's a little bit of the wild, wild west because DRGs aren't controlled, meaning what's put into that bundle is not controlled by, CMS or anyone else. So we have to do quite a few things to normalize it. But, one thing, Daryl, which I didn't mention, is the size of these data sets. So these data sets, and for those of you, this is a test. Do you know what a petabyte is? Do you know what a petabyte is? Well, I didn't 5 years ago. I know what a petabyte is. So a petabyte of data is equal to, making it relevant to, a layman's terms. If it were a digital song, it would take you 6 years to listen to it. So we are filtering through petabytes. We're almost up to 3 billion rows of data, and over 153 health plans in the United States.
Wow, that's a lot of data. Are you having to use IBM's Watson to analyze all this?
No, we actually have a strategic partnership, but we use data science as well as AR learning. And so we're trying to, as the data, we refine the data and refine it, that we're able to get to this. And as Daryl mentioned, it wasn't that our objective was to be first to market on this, because we didn't know what we didn't know. And when the payer data sets were released in January, and all of a sudden we were, there was a lot of, phantom claims in there. I mean, literally a dentist that was doing a knee procedure. So we had to clean the data almost like a fraud, waste, and abuse before we even started the evaluation process.
Heidi, are you acquainted with Cynthia Fisher, one of our other advisors? She's not on the call today, but do you know Cynthia?
I don't know Cynthia well.
So Cynthia is the person who spent 6 months in the White House getting the transparency.
Oh, yeah. Okay. Yeah. I know her name. Got it.
So,
yeah, we need to connect with.
I was going to say, at the Rosetta conference in Chicago a few months ago, as she presented from the stage, she mentioned a need to have this kind of robust sharing the data. So I will connect you with Cynthia. I think she would love to hear about what you've done with her efforts to create transparency, to see what you've done to make it happen.
Yeah, because there's been some, and as you can well imagine, everybody here on the call, we've been in these contract black boxes, in the gag clauses, and we see data, we've questioned data, but yet we're not authorized to question it, and we're restricted by what we can share to the market. So this is, these new transparency laws have opened that door for that type of conversation. And to be able to do that effectively with, people like ourselves as a business associate for employers is going to be key in the future.
Nice. Maybe you have any questions for Heidi?
Oh, come on. I couldn't have articulated it well enough not to have questions.
There's got to be questions. And we'll do another one where she can actually show it to you, but anybody have any questions about the concept?
I have a question. So if I heard you right, as you were talking through the claims data, I heard stuff relative to cost. Can you speak to how you were parsing it relative to quality? Because I heard you say that's in the overall plan or the overall scope, but I didn't quite understand how you guys are judging quality at today.
Yeah, great question, Mark. So what we do is essentially CMS uses HEDIS standards in order to evaluate their quality measures, and they do it by stars. Okay. What the partner that we're working with, if you're familiar with Quantros, but Quantros, yeah. So essentially what we've done is we've ingested the Quantros data set in order to then bring that against the quality, just really to evaluate providers down to the NPI level. So NPI, for those of you who aren't extremely familiar, is the National Provider Identifier level. So we're able to actually do that quality scoring down to the NPI level and be able to show that. And I'm going to tell you what Daryl says, and Robin, what you shared today, cost and quality are not synonymous. That some of the highest quality providers have some of the lowest costs.
It's actually, in my opinion, the biggest opportunity, if total transparency happened tomorrow, is the fact that unlike any other industry we know, it's exciting to think that the best quality is often in the lower 20 percentile of the cost.
Yeah. And so when I say so Mark, part of the reason why we did that is that cost is not the full equation, right?
Right.
But there is also, I would just tell you, because we're in this kind of open dialogue, collaborative space, there's really a race to changing the quality as well. And the reason being is, from a pop health measure, you can't say everybody has to have these things because, we are different beings. And so there is a huge rush to being able to, by procedure, come up with quality scoring measures. And we're already seeing that. Garner Health is one of them.
I'm familiar with Garner.
That they've created a separate tool that is outside of their overlay. We are seeing, Healthcare Blue Book, which is part of Quantros, vice versa, that we're seeing a lot of this race to quality measures differently.
And I do want to tack one thing on to something Daryl said when he was talking about Cynthia, and she had mentioned on stage about eagerly looking for the transparency tool. She also was eager to offer to even the group of hundreds of people that they would be excited to help fund that, to push it along.
Oh, wow.
Yeah.
Well, we would love, we're a global organization, but we still have private equity. And I'm going to tell you, we have literally, Daryl, normally gets a call from me once a month or at least once a quarter. Other than these calls, he hasn't seen me in probably 2 years. So, and part of that essentially is just keeping our head down and literally neck deep in this data. And we do see, just for everybody's edification, the 4 pieces of legislation that have passed the House that are in the Senate, because we try to support policy efforts, that there's several of those that are a little bit stalled, but we're seeing a lot of momentum on the audit side. And, that's really, I think we finally have gotten, our legislators, at least at a federal level, up to speed on some of the need for transparency in healthcare.
Nice. Can I connect some dots?
Sure.
So, as many of you recall, Heidi and Lee presented a few weeks ago this amazing tool that is now available to all of you, to employers and brokers, open source, white label it across the country. And when we were on that call, I asked her specifically about this ability to identify cost and quality, and for the navigator to be able to direct people to the right place. That is what she's describing. So you bring these two together, and I'll let you kind of talk about how they work together.
Yeah, so it was kind of interesting as we were solving, real quickly, as we were solving for the challenge in the mid-market. Lee Lewis, as you know, from Health Transformation Alliance, has done such an incredible job with these jumbo employers. But as you know, you can't aggregate employers for purchasing insurance, or you have a MIWA. Okay, and we didn't want to violate any MIWA laws. So what we did is that I spent literally probably almost 2 years, because NFP, even though we have, 375 offices and over 100,000 clients, that we still didn't have enough volume to pull levers to be able to negotiate directly with point solutions, et cetera, and be able to effectuate kind of a cost difference in the market by bundling them. And so just, with all the committees and relationships, even though this industry is large, there's a small group of people like VDAR and all the efforts that VDAR has done, and Health Rosetta. And there's a few of us that have tactically said, okay, we're going to squelch the narrative. We're going to boots on the ground, make something work. And so collaboratively, I went to Lee and said, Lee, look, can we do this? Let us kind of quasi-lease what you've done under Health Transformation Alliance and put it into the mid-market. And so essentially that's what we did. And in doing so, what it does is it blends both what we consider best practice in the, jumbo size employers, and bringing it down mid-market to bring really a private solution, not a federally sponsored program, but something that we, from an entrepreneurial standpoint, can bring to the market. And within that, Robin, kind of to what you're doing, we have direct primary care or advanced primary care solutions. We have clinical care navigation. We have a lot of the key elements. So all we did is, if you were to look at a fully insured plan or product or anything that's sold out there, we deconstructed it. We reconstructed it in a self-funded environment. We put it on a chassis of a captive stop loss so that we can aggregate employers for risk purposes, which is really key, and it doesn't violate MIWA laws. So the Department of Labor basically came out 5 years ago and said, stop loss is not insurance from the standpoint of insurance. So we can aggregate small, mid-sized employers all across the country into a captive, put on this high performance chassis, which is this clinical, risk group that Lee has built, and then put all the third-party administration services. And actually we actually have a captive that's established that we're moving into. And once we have enough growth, we'll have our own captive. But essentially, by doing that, we've already seen, and we just barely announced it. It was Aspirational where we announced it, and then VDAR invited us to Health Nation. And we already have a dozen that we have quoted and that are in the process of being adopted into the program.
Awesome.
So yeah, we're excited.
And let me put it in my context, or in simple words to me, what's been created here is the opportunity to take full advantage of subscription-based advanced primary care, direct primary care, all of the benefits of that. And now when someone needs to go beyond that, you've got this navigator who's got this tool that Heidi just got describing, where we can direct people not just to a network provider, not just to say, oh, just because the network is Aetna, or just because the network is, Cigna, or just because the network is, it's like, no, the data that's now been compiled with Heidi's tool can be used by the navigator to point people in the direction of the best quality provider at the best price. It's like, it takes care of almost the entire spectrum of both quality and cost.
Yeah, our tagline is right care, right time, right provider.
Yep.
So, you know, not that, hey, and everyone here, you know, no pride in authorship. If you say, Heidi, have you ever thought of this? Or Lee, have you ever thought of this? Can we do this? That we just knew that we had to get moving and moving in a direction that would effectuate some change.
Well, that's the purpose of this group, is to infuse more and more collaboration all the time.
Yeah.
Who's got any questions I've got one more thing I want to share with you that I just thought of. But anybody have any questions for Heidi of what we've been talking about? Vidar, do you have any questions?
Good.
It's good to see you.
Yeah, nice to see you.
So a couple of weeks ago, I happened to attend a healthcare leadership conference. It was at Brigham Young University, just close to where I live. And they brought hospital leaders and healthcare leaders from across the country, about 250, into this conference. And while I was in the conference, I went into one of the breakouts, had about 50 or 60 people, and everybody went through all the breakouts. And one of the presenters put up on the screen a diagram that I have probably described ever since I left running hospitals. I mean, I do it all the time, but I'd never actually thought of someone from the hospital industry putting it on a diagram. I'm going to show you my screen.
So, Daryl, I have a question for you. Do you think that hospital administrators understand the employer lane at all?
They're just beginning to understand it. It's like they wouldn't even think about it 27 years ago. It's like, that's not our business model. But I heard at this conference, I'll tell you what I heard. So can you see my screen?
Yes.
Okay, so I won't go through the whole thing, but there we go. So, so he actually put on the board, this is my taking a picture of what was on the board. He said, okay, this is how we're orchestrated. This happened to be Providence, but it represents all the healthcare systems. Right here is this little box called patients of our employed primary care providers, 2 red small dollar signs. And of course, the black hard line is more desirable referral flow. So we want to send people into our specialists. So this is employed or foundation specialist. Again, 2 small red dollar signs. Why? Because they buy these things because they don't make money. But here's the key. Our own hospitals, ASCs, and imaging centers, big $2 signs green. So it's like our model is based on, we buy these practices so we can fill up our hospitals where we make the money. It's like, oh my gosh, somebody actually put it on a screen, on a PowerPoint. And of course, they're showing down here that if people, leak out less desirable referral source into these other places, then it hurts us because then it goes to our own hospitals. So the next screen, this was just so you can see it a little closer. The next screen was, this is what he said. He goes, do you want to know what worries me the most? And he brought this one up. We're losing our foundation. The primary care practices are being bought up by the CVSs, the Amazons, the Walmarts, the Walgreens. Employers are going directly to these, primary care practices. And oh no, we're losing our referral funnels. And I'm like, you got it. That's exactly what we've been working for a long time. And you now recognize it. So anyway, I had to show that to you. I had to share that with you. Thought that was so interesting. And the interesting thing is that from his perspective and his presentation, I raised my hand and I said, oh, and just by the way, the biggest companies in the country are moving in this direction very quickly. And his comment was, that's what's needed. He actually was seeing this as, this is a problem. I may be representing a hospital system, but this is a fundamental problem. And it's a good thing for the industry that we're moving in this direction. But he still said, we're worried, we need to become more aware of what's happening so that we can respond. So in my mind, this is amazing. Now, this was one little conference with 250 people, but I think they're waking up. Does that answer your question, Heidi? I think they're beginning to understand.
Yeah, I think that we're going to see, like you said, there's going to be winners and losers in this. There's going to be the early adopters, and the early adopters, hospital systems that embrace some of the change and start realizing that they're not just going to be able to open the doors and they will come,
Yeah.
that they're going to have to market differently.
Yeah.
I think the hospitals are just becoming aware of the purchasers of health insurance, and employers being one of those. They really don't understand the depth, or the gulf of different perspective between they as the center of all providers, and that's in the DNA, versus these employers in the community. They're still pretty much on a different wavelength, but at some point they'll come around, I
I
think.
think we're coming around. I was presenting probably 3 years ago to the local chapter of the Hospital Administration Association, and I kind of shared where I saw things headed back then. And they raised their hand. They said, "So what you're telling us, Daryl, is that hospitals in the future will need less beds." Like, you got it. And interestingly enough, I'll give IC credit. So Intermountain Healthcare was presenting with me, and she actually said, "We've made a board decision to do just that. We are literally, when we have to open up a new hospital, we are not opening up as many inpatient capacity, because we see in the future that a lot of healthcare can be done outside the beds." So to give them credit, I thought that was great. But yeah,
That is compelling. Yeah.
we've just got a few more minutes. Anybody else have any questions or comments or thoughts?
I've heard that comment from the CEO of Intermountain saying that they would see reducing the number of beds as a success, and I've never heard that from any other
Anybody else?
hospital executive. No one. Intermountain's in a class by itself in that regard.
They actually are, run by a very community benign board. It's a very unique healthcare system that has really led the way in many ways across the country at what's best for the community. All right. Well, thank you, Robin, for presenting today. And thank you, Heidi, for being on the spot. And what we'll do is we'll actually have Heidi scheduled for one of our upcoming to show the tool, because it is pretty cool what they've built.
Thanks, everybody. If you have questions, reach out. Happy to answer any questions. Thanks.
Thank you. This was great. Appreciate it.
Thanks, everybody.
Bye-bye.
Thanks. Have a good weekend.
Thank you.